welcome back to Fertility Q&A with Dr. Rohit Gutgutia, brought to you by www.ivfnxc.com. In this podcast, we aim to provide you with all the information, support and inspiration that you will need on your journey to parenthood with assisted conception. So whether you're already on this journey or you're here only for information, this podcast is right for you. So just sit back, relax and be prepared to be well informed. Dr. Rohit, as always, it is a pleasure to be having these discussions with you. Over our last 4 episodes of podcast, we have covered all the important steps that a TTC couple needs to undergo before they seek the help of a fertility specialist. And this is the last episode in this series in which we will be covering everything that a couple needs to know about assisted conception methods. So, Dr. Rohit, the Indian IVF industry has undergone a sea of change in the last 40 years since its inception, and now it is at par with global standards. Although there is a lot of awareness in India today regarding the fertility treatment methods, very few people actually know about the inception story about IVF. So before we dive into the heart of the topic, I would like us to explore how it all began and what were the significant leaps that the IVF industry has made in its transformative journey to becoming a globally recognized industry over the 40 years period, and more importantly, what are the challenges it has had to overcome to bring it at par to global standards. So if you can share your insights on that.
This is a very difficult question to answer. Let's start off by complimenting you that in the last 4 episodes what we've done is actually mammoth. We've covered almost everything that could concern a couple that's trying to get pregnant. And continuing the same vein, let me also thank you by starting off by calling this an assisted conception story. The commonest myth or confusion that I encounter is most people, even amongst my community, sometimes they mention the word artificial and not assisted. So yes, we are an assisted, ART is assisted reproductive techniques. It is not artificial in any which way. Now, to share the story of the evolution of ART, it's very fascinating. Right after World War II, because so many people died, there was a huge interest in how to improve human fecundity or ability to have children, and research started on this. And the long and the short of it is, the community was prepared in a way that some sort of an assistance was available for couples to improve their fertility if they so desired. There's something called clomiphene, which is a medicine to induce ovulation in the ovaries. That was available almost in the 1960s. Then you had urinary gonadotropins, injections again that are used to stimulate the ovaries, that were also in currency. People started using it in the 60s. So all this was available, and research was also going on. And there were scientists across the world who were trying to make babies outside of the womb in the so-called test tube, actually not test tubes but dish. So you had a pregnancy through IVF in 1971.
Oh, wow.
This is far earlier than what we assume as the birth of the first child in 78 as the start of IVF. No, IVF had actually started before that.
So you're talking way before Louis Brown.
Long back. And this was a pregnancy that ended in a miscarriage. And because as a society we worship success, therefore this is not so much recorded or is not talked about, but actually in the sense that the embryo being created and being implanted in the womb and a pregnancy happening, it happened in 1971. And I'm talking about humans here. Then of course we are aware of the Louis Brown story. A scientist and a gynecologist, they put together the whole story, and we do not talk about, or usually do not talk about the female scientist also involved in the whole thing. So actually it was not a couple, it was a troika, and they worked together in a hospital and they created the first baby, and this eventually was born on the 25th of July 1978. And it was hailed as a miracle of science, and people all know about Louis Brown. But here also I'd like to mention that this was by no means the first attempt. As far as I remember, this was the 173rd or 172nd attempt at trying to get a pregnancy, and which is when we got success. What is remarkable is while these attempts were going on, each of these steps were recorded, diligently recorded by the scientists involved in this process for posterity, and therefore there was this entire log that's available for the scientific community to look at and then understand the whole progress of the IVF struggle that this scientist underwent. Parallelly, an individual in Calcutta, in our own Calcutta in India, an individual called Dr. Subhash Mukherjee, who was a reproductive physiologist, he was also doing something similar, but his was a unstructured, unfortunately so, because in India you do not have the facility that the Western world enjoys, and sort of an unstructured attempt at doing the same thing. And he also achieved success, and his child was born some 75 days after the first child was born. So in a sense, the second baby in the world was born through IVF in Calcutta in India.
That's interesting.
But it's so sad that because the whole effort was not documented, it was not talked about in the scientific community, when that gentleman actually went out to talk about this, he was met with resistance, with incredulity on behalf of us, the practitioners. We thought that something like this could have never happened in our city, in Calcutta. And he did not get the kind of reception that he deserved. And unfortunately, he went on and committed suicide. So that's kind of a black spot on our scientific community forever. But coming back to the good things, so with evolution, the whole process of IVF got standardized. Initial days, IVF was very unstructured. Women were given medicines to allow the follicles to grow, but we had no clue as to when they would ovulate. So they used to be kept in hospitals. The blood used to be analyzed every 3-4 hours to see whether the eggs are ready to ovulate. And almost as if an emergency operation used to be carried out, the moment we felt that she might ovulate or may have ovulated, to collect the egg through laparoscopic route from the tummy. And you would not get eggs in most of the cases. Even if you got eggs, you would get maybe 1 or 2 eggs because you have not stimulated the ovaries to make multiple eggs. There was no method by which we could freeze the extra embryos that we were creating. We had to make the embryos in that very cycle and put it back in the womb in that very cycle. And that was very tedious and not always very comfortable for the patient concerned. So all this made IVF a very luck and a chancy kind of a thing for the patient. But the demand was such, the requirement was such. Honestly, even the scientific community was not aware that there's so much of a desire for a child that's there, because we've always assumed that human fertility is a given thing. That by early 80s, 5-6 years after the first child, there were units across most of the Western world. In India also, 1987, we had a unit in Calcutta. Dr. Baidyanath Chakravarti, pioneer of structured fertility treatment, his unit was also up and about, and they started doing structured fertility management. And then as time went by, things improved. We had medicines which could control the ovulation process. We had medicines which could make multiple eggs grow up. The egg collection was no longer required to be done through the abdominal route. It could be done through the vaginal route with the help of an ultrasound machine. So there was no need to hospitalize the person concerned. Embryo making, culture of the embryos in the lab, that became most standardized. We had different sorts of media which were available where the embryos could be grown without risk of causing contamination or infection to the embryo. We learned how to freeze these embryos to be used later on, so then we could utilize the embryos in a subsequent cycle. So all this then became standardized. We understood the value of pH, temperature, air quality, controlling the ovulation process. We learned the science. Technology helped, microscopes improved, optics improved. So all put together, it took the shape of an industry. So today we use the word IVF industry very blithely, very casually, but the start was in a thought with some revolutionary, far-thinking individual scientist in the early 40s of the last century. And today we think that there are more than 10 to 12 million babies across this world who have been born through this method. So that many couples who have been blessed with parenthood through IVF. So now we can say that IVF is reasonably safe. It is predictable to a point that successes can be predicted even before we start the procedure. And therefore, it's now become more or less like a commodity. We can plug and play, we can apply the science to a large majority of our couples. And therefore, we use the word IVF industry now.
Yeah. So in the last 30, 40 years that we have seen the growth of IVF industry in India, if you see the growth, in the last 10 decades, there has been an unprecedented growth in IVF compared to the previous 30 years. And yes, all the advancements and achievements that have happened in the last 10 years, not only have they given hope to millions of couples, as you say, it has also positioned India as a global leader in the fertility industry. So my question to you is, what are the factors do you think that have helped in this growth in the last 10 years?
So this could be applicable to a lot of other things also in India. See, India is today in a very sweet spot. We are growing economically, and our people are going out, working in the best of societies, best of conditions all over the world. We are learning, imbibing new things very fast. So we are a fast developing nation. With what happened with the IVF industry, as we discussed, the standardization, along with that, there was an acceptance that grew in the public about the whole process being safe and being reasonably successful. So more and more couples came forward to embrace this technology to have their children. And when that happened, when the demand was there, the supply automatically found itself in the right place. Initially, let's say in the 90s and in the early 2000s, training was not available. So you actually had to earn money as a general practitioner, as a general OBG practitioner, go out of the country and train with the best across the world at your own cost by staying with them for some time, which essentially meant that your practice could get hampered in the country. So very few people actually ventured out to do that. And then there was this embryology learning that had to happen, and you had to either train somebody in your system or get trained concurrently in the embryology part as well, and then come and start the IVF practice. So there are a lot of hurdles. Very few doctors would set up an IVF unit and be able to run it successfully because there were many couples who did not want to get an IVF done. They wanted a natural conception because they were not very sure about what the method is and what it will entail, whether the baby will be healthy at all or not. When there was a lot of proof that got generated and people read about it, heard about it, and also saw this happening across the world, the demand grew. And in India also, we had this structured training system that got into the system by late 2007, 2008. You had the first structured training program that came in, and that actually led to an explosion of new clinics, new doctors, well-qualified doctors, well-trained doctors came out, and they were structured in their thought processes, in their trainings. And when they came out and started practicing, the IVF process became mainstream. And today we are in a scenario where we are possibly the fastest growing IVF industry in the world. Our centers are flourishing. We have patients, clients in all the IVF units across the country. I would not say that the practice is fully standardized across the country as yet. There are people who still have a lot to learn, and there are centers which do possibly the best work across the world right here in our country. So there is this imbalance that still exists. But by and large, across healthcare, IVF does stand out as a shining light, an example of India's eminence in the world of healthcare.
Yes.
So we have people coming from all over the world now to India to get their IVFs done because of the cost factor, because of the reasonable procedure, the explanation that we offer to our clients, and the structure, the infrastructure is almost equal to anywhere in the world. So all put together, it seems that we are in a sweet spot where clients do find us the right kind of mix of technology, empathy, and success, and therefore they're coming here.
Okay. So how is India doing on the research for part of the IVF?
Okay, so because we are now the largest country in the world in terms of population, it does make sense that now we move into the research part. The incentive or impetus to do research is not there, unfortunately, because most of us are private practitioners, and in private practice, majority of our time goes in managing clients and rather than doing research work. But because as IVF is now becoming industry, it's becoming more organized, more structured, corporates are getting into the picture, and they are having research wings. Even individual doctors are very strong on research, and they're pushing that agenda together with professional societies that have also grown in stature in the last 2 decades. So not that we have a lot of research to boast about in the past, but that is also bound to change in the next decade. I strongly feel and I strongly believe that India will be the hub of research in reproductive medicine in the next 20 years.
That's great news for people who are looking for fertility treatments in India. So moving on to the treatment part of the IVF part of the thing. So when it comes to treating infertility, so we hear this quite often that there is no one fit approach to all. So what works for one couple may not work for another couple. And there are so many treatment methods in IVF. So it becomes a little confusing for the couples, especially to understand, when a method gets recommended to them and why it works for them, why it doesn't work for others. So I would like to explore this part a little bit with you. Can you explain what are the various methods in assisted conception, and how do you decide which method of conception is better for a couple?
Okay, so we have a lot of jargon and a lot of acronyms. And understandably, couples are confused when these acronyms are bandied about by us very, very casually in front of the couple. And they obviously want to understand why this is being recommended over this, and what would have happened had we not gone with this and gone ahead with that.
Yes.
So let's try and unscramble the whole thing for you, and let's try and understand what is what and why is it recommended. So we have 3 things that are most commonly used. There's something called the IUI, which is intrauterine insemination. Very simply, a pregnancy happens when a sperm and an egg unite. The sperm is deposited in the female reproductive tract, usually by coital activity. Sometimes that coital activity is not possible. The partner stays elsewhere. He is not capable of having a physical contact with the female partner. The female partner may have condition where she may not be able to have physical contact, or the sperm quality may be such that post physical contact enough sperms may not be able to travel till the egg. So in these circumstances, what we do is we take the processed sperm of the male partner and put it in the female womb. Now, to call this assisted reproduction is a little challenging, because by common sense you would assume that we are actually assisting in the reproduction process. Here there is no assistance. The sperm is being delivered into the womb, but it has to travel on its own to the egg, which is hopefully lying in the tube, fertilize it on its own, create the embryo, and allow the embryo to come and settle in the womb. So this is not really a ART technique, but because of historical reasons, we continue to call it an ART technique. One reason why we might call it an ART is also because the human gamete, that is the sperm in this case, is being handled outside of the body. So this is the most basic, the most commonly advised method of trying to get a couple pregnant. Unfortunately, the IUI application is huge, but the IUI requirement is very little. Because you would want to do an IUI only in a situation where sexual contact is not possible.
Yes.
But because IUI is a simple technique, there are hardly any injections involved. There's not much of an hospitalization or putting under anesthesia involved. It is far more acceptable to the couple who has been trying naturally to get pregnant and now has been advised that no, you need to see a fertility doctor to get pregnant. That couple is understandably disturbed. So while that couple has accepted that scenario that they have to take the help of a fertility doctor, in their heart of hearts they still believe that they don't need anything bigger than an IUI to get pregnant. So the compliance of the couple to start the fertility treatment with an IUI is very high. So which is why most of our colleagues tend to advise IUI far more than actually it is supposed to be advised. And there's this historical thing that continues even today. But believe me, the funny part is that an IUI success rate is a measly 5-7% per cycle or per month. So this is hardly different from, let's say, a natural success rate of around 10-12% in a young couple. So if we were to explain this to couples who want an IUI done, maybe most of them would back off. But again, the same problem exists, that somehow they believe that maybe in their case it's going to click. So they actually want to undergo the whole rigmarole of an IUI happening and then not succeeding, and then they're thinking that now it's time to move on. So there's a charade that goes on in the name of IUI mostly. But if you apply IUI properly meaning couples who are actually having a sexual discordance and therefore the pregnancy is not happening, there the IUI pregnancy rates are decent, 15% plus. Or in situations previously when you used to do donor insemination, there also the pregnancy rates were a decent 15% odd. So that has to be kept in mind. So that is as far as IUI is concerned. Now let's talk about IVF, which is basically the bread and butter of ART. So IVF stands for in vitro fertilization, and that is something that is obviously known to everyone now. So IVF is where we put the egg and the sperm together, form baby outside of the body in the test tube or in the dish, and then put it back in the womb. Why would you want to do an IVF? Because if the fallopian tube, which is the natural place of fertilization in the body, that's not working. So that's not allowing the fertilization to take place. So therefore you take the egg and the sperm out and you do it outside of the body. This is the classical indication. In fact, initially tubal disease was the only reason why IVF was being recommended. But now actually IVF has evolved to include a lot more indications. If anybody is not getting pregnant for the last 2.5, 3 years of active married life, then an IVF is recommended. And what we get out of IVF is pregnancies even when the tubes were actually functioning properly. So it could be that there are in certain couples a situation where the sperm is not able to fertilize the egg, or maybe the egg shell is so thick that the sperms are not able to enter the egg, penetrate the egg. So we really do not know the real answer or the right answer or the proportion of couples who would benefit with an IVF. But over time we've realized that an IVF is a very efficient method of creating embryos outside the body for any which couple who are not conceiving naturally.
Yes.
Now a subset of IVF is ICSI. What is ICSI? Intracytoplasmic sperm injection. So we inject the sperm inside the egg to form an embryo. As I mentioned a couple of seconds back, that there could be a situation where the egg shell is thick or the sperm is a little lazy and cannot penetrate the egg on its own, but it's still available. In those situations, if we physically take in sperm and inject in the egg, maybe we will form an embryo. So classical indication for ICSI was 1990s for severe male infertility, where you did not have even those many sperms which could cause fertilization through the process of IVF. And now we say that ICSI is actually such that it has killed embryology, meaning with ICSI you are able to take care of almost all cases of male infertility. So there is no more any need to diagnose and treat male infertility. You can actually do an ICSI and get them a pregnancy and they are happy about it. So between the three of them, IVF, ICSI and IUI, you pretty much covered the entire gamut of treatment modalities available.
Yes.
But because we love to use acronyms to impress our clients, and clients are also looking for something new, there are there are situations where now getting into more details and newer acronyms, and people are always wanting to know from us what are these things all about. So there's something called IMSI. In IMSI, it is also a variation of ICSI. In IMSI, what we are doing is nothing much. We are magnifying the sperm far beyond what we usually do when we inject the sperm into the egg. Why do we magnify the sperm so much? And how is it possible? Because optics have improved. So we take an image of the sperm, we digitally enhance it, we enlarge it, and we look at the insides of the sperm to see if it is looking healthy or not. The criticism about ICSI was that we were bypassing the natural method of selection of sperm. And we could be potentially creating embryos or maybe babies which were not healthy.
Not healthy.
While today we know that that is not really true, ICSI does create embryos, but most embryos which are not healthy are rejected by the body either before implantation or after implantation. So as such, child that's born is no different from the child that's born through an IVF or through IUI or natural birth, for example. But that thought persisted. So people wanted to improve or refine the process of ICSI if they could super select the sperms. And one of the methods of super selecting the sperm is by magnifying the sperm further, and therefore you have IMSI, IMSI. Another of those variations is PICSI. So in PICSI, you do not magnify the sperm, you select the sperm by physiologically doing a selection test.
Okay.
Now the sperm has actually got to bind to the egg to be able to penetrate the egg.
Yes.
And it binds through a natural binding protein which is available in the human body. It's called hyaluronic acid or hyaluron.
Yes.
So what we do now is we use a dish where the sperms are let loose, and the sperms that will actually go and bind to the HA which is present in the dish, maybe those sperms have the binding ability, and we pick out those sperms and inject into the egg. So maybe these are the queen sperms or the best sperms who have a finer ability or a better ability to bind to the egg and enter the egg, and therefore they could possibly give us healthier babies. So now I am talking about 5 acronyms: IUI, IVF, ICSI, and then there are 2 divisions of ICSI, the PICSI and the IMSI.
Yes.
The whole story is basically, as every day passes by, there's a scientific community that's at it 24/7, trying to find out methods by which it can mimic nature, select the right sperm and the right egg, form the right embryo, the healthiest embryo, and put it back in the person's womb. The whole process has evolved from trying to make multiple embryos and keep transferring till we get a pregnancy, to a situation where we are trying to create maybe less embryos but healthier embryos, and trying to select the right embryo before we transfer, so that a person does not have to go multiple transfers. The underlying thought behind this is that every embryo transfer is quite like the experience that a person undergoes. A failed embryo transfer is quite like the loss of a child.
Yes.
So although there is a strong distinction that needs to be made by the clinician to the client, that do not consider an embryo as your baby, because the moment you start attributing emotions and imagery to your embryo, you're actually making some assumptions in your mind, and we're not supposed to do that. But human mind is human mind.
You can't help it.
You can't really help it. So we are trying to reduce the number of embryos to be transferred, or the times that we have to transfer an embryo, to the minimum, so that a person does not have to fail transfers. She gets pregnant at her best shot of transfer, and that's how we're trying to take the whole science forward. One of the methods why we're doing is by selecting the embryos after they have formed. And that method is the method of PGT. So PGT stands for pre-implantation genetic testing of the embryos.
Okay.
An embryo or a human being is made up of 46 chromosomes, 23 are derived from the male gamete, 23 from the female gamete. Not all embryos unfortunately have the same 46 chromosomes. Some may have multiple number of embryos in excess of 46, some may have 1 or 2 embryos, chromosomes missing. These embryos are not destined to be healthy children. So if we could select these embryos on the basis of their chromosomal count and transfer only those who have the right amount of chromosome, the 46 chromosomes, maybe would have a higher chance of a healthy pregnancy. So then there's a test that's available. We extract a few cells from the growing embryo, analyze those cells for the number of chromosomes that they contain, and select the embryos that only have 46 chromosomes and transfer it back. This could also be used for single gene disorders, like thalassemia is very common in this part of the world. We could rule out thalassemia by a similar technique, and then these selected embryos are known as PGT selected embryos. So I have tried to give you as many acronyms as possible.
So of all these techniques that are working here, what do you think, how do you recommend which technique goes with which couple? How do you decide? Like the add-ons, you are recommending IVF, but then with IVF, whom would you recommend ICSI, whom would you recommend MC? How do you select this? How do you choose this?
So again, a little difficult to really discuss this out in abstract, but in essence, you don't want to do too much for a couple because all of these scientific techniques or technologies have their own drawbacks. At the same time, you don't want to do anything that should have been done, and you don't want to regret not doing that, especially because the client is so well read and has an understanding of the whole process and would want to be participating in his or her own treatment. So in that kind of a background, let me put it out to you that an IVF works fine for 80-85% of your client base. They're not getting pregnant because simply the eggs and the sperms are not uniting. You unite them in the lab. You allow those embryos to grow in the lab till at least they are blastocysts, because by that time most of the bad embryos would have stopped growing, and then you have the embryos that have actually survived the first 5 days of formation, and select them and you put it back in the person's womb. If, however, that person has failed IVF before, then you actually want to do something more for her. Now, most of the techniques or technologies that are available to do more for the client do not have strong scientific basis. And I have been practicing for 2 decades now, and I'm a strong believer in doing that much that is necessary or is acceptable to you as a clinician. So what we would feel that making embryos is best done by as natural a method as possible. If that's an IVF, life is good enough. But if there are too few eggs, or if the sperm quality is a little iffy and you're not very sure whether an embryo would form, or if she has had a failed fertilization in the past in your lab or in somebody else's lab, then you definitely want to do an ICSI for them. When do you choose to super select the sperms? When the semen analysis throws up a report that the sperms are mostly bad looking and they have defects, that's when you want to select them on the basis of looks. So that's where the magnification comes in, or the MC comes in. If you have a situation where the embryos did not form the last time, or the embryos did not continue to grow till blastocyst after ICSI, or that person had an implantation failure, or she had a miscarriage, or God forbid she had a baby who is not healthy. In those situations, you would want to do a PICSI to be able to better select your sperm. If there has been a miscarriage or a multiple miscarriage which is not explainable by anything else, they have a family history of a genetic or a chromosomal disorder in the family, then you would want to select your embryos by doing a PGT and then transfer that embryo to that person's womb. So this would be the techniques that I would say have a reasonable degree of science supporting them. Then you have certain other methods and certain other techniques which do not have science supporting them but logic supporting it. So what we do when we select our embryos is to take them out of the incubator, look at them under the microscope and select them on the basis of looks. Because we cannot continually observe an embryo, we select them on the basis of looks as when we see them, which is hardly for a couple of seconds throughout the day. So if we were to observe the embryos in the lab continuously without disturbing them, through a microscope on them, in the incubator while they were growing, then we would get a 24/7 assessment of the embryos only on the basis of their looks. So that technique or technology is now available. It is not harming the embryo in any which way. So that's known as time-lapse imaging. So you have a video kind of a thing where you can look at the embryo throughout the day, and that helps you, possibly that helps you to select your embryos better.
Okay.
So while there's not so much of science supporting it as yet, the logic is very strong to support it, and because it is not really harming, we can use that for people, especially who have failed transfers before. Extension of that is AI-based selection of embryos. So what we do for embryo selection is basically we select on the basis of looks. And how do we select? We look at the embryo, we look at the regularity, the symmetry, and then we decide that this is a good-looking embryo and therefore this has a high chance of implantation, and this is not so good-looking and therefore it has a lower chance of implantation. But remember, this is a human eye looking at the embryo for less than a minute and deciding. If there was a neutral or a objective matrix to do the same thing, maybe we would have trusted it more. So then there are now AI-based tools where we can take the image of the embryo and then magnify it, and those AI techniques have 1600, 2000 points by which they grade the embryo, and we can use that tool to grade the embryos and then decide which embryo to transfer first. Again, the same story, not much of science supporting it as yet because these are all new things, but we are not causing any harm, that's for sure. It is a better technique because it's an objective technique and it can be applied to the embryos, and data could be generated at your own clinic, and you could actually compare your human eye estimation with the machine and then try and understand which works better for you. So these are two things which have logical clearance from my side, although the science is not very strong. And then you have things which are neither logically sensible, not scientifically sensible, like injecting stuff into the uterus, whether it's a PRP, stem cell or HCG, or injecting stuff in the ovary, because if the eggs are not there, you cannot really push stuff into the uterus and the ovaries to make new eggs. So there's neither the science supporting it nor logic supporting it. So you need to differentiate between what you can do, should do, and what you want to do for your couples in terms of these add-ons, and then move on.
That's interesting to know. Dr. Rohit, where we have come across a lot of advertisements where clinics are talking about state-of-the-art labs and cutting-edge technology in IVF labs. So I think I would like to explore this a little bit more so the listeners understand about the technology. So in my next set of questions, my first question is, what are some of these advanced technologies and techniques in assisted conception available in India, and how do they compare to the global standards?
Okay. Again, to put it very simply, technology by the whole name itself implies that this is something that is changing almost on a daily basis. So nobody can really claim to have cutting edge technology, because whatever that I have in my system today is most probably going to be outdated tomorrow. So I need to keep reinvesting in technology to the extent that I can actually justifiably claim that I am actually at the top of my game. So while we use these terms very often and sometimes without any basis, there has to be a basic understanding of these terms, at least from my public's point of view, from my client base points of view. So the lab is a very sensitive ecosystem. The air quality in the lab has to be just right. The temperature, the presence of particulate matter, the presence of infective or contaminating matters such as bacteria, viruses, even things like organic compounds, that should be minimized or kept absolutely zero. And the air should have certain parameters in place, in the sense that the oxygen concentration, the carbon dioxide concentration, all should be in the healthy ratio. Even the humidity in that air has to be controlled. So how do you ensure that this air quality inside the lab is so precisely maintained? So you have a closed system called the lab, and you have air pumped into that lab which has been filtered and cleaned up on a regular basis. So this is the basis on which we can claim to be a modern lab. So any lab which does not have an air quality system in place does not have a modern lab. That's basic. Then you have the culture systems and the embryo screening methods or screening environment. You handle the eggs and the sperms very often in the lab. You want them to be kept in the right temperature and the air quality. So you have workstations. Ideally, those workstations should have minimum of disturbance. There should not be exposure of the air inside the workstation. So you have the laminar airflow workstations. Sometimes those workstations have closed chambers, so you can only insert your hands inside to work on them, so that the air inside the laminar flow is not contaminated from air outside. And mind you, this is the air of the lab, which in itself is well controlled. So you want to go a step higher, and you want to have the best quality of air immediately surrounding the eggs and sperms when you're handling them inside the laminar flow. So that is again a basic requirement. You need incubators to handle your gametes. Now incubators, you could have one incubator in your lab, you could have 10 incubators in your lab. Remember, these incubators are like refrigerators. They are doors that have to open and they have to be shut down. And every time that you open the door or you take the drawer out and you put it back, you disturb the air inside. So you should have enough incubators in your lab such that you don't need to open the drawers many times during the day, because one patient or one person's embryo is required to be checked at least once, and you need to open the door at least once in a day. So if you're culturing 2 patients or 3 patients' embryo in one incubator, you have to open it 3 times. So keeping that ratio in mind, if you are actually in a situation where you have one incubator or one chamber dedicated for one person, then that's the best case scenario for you, because you're not needing to disturb it for other persons checking. So that comes again the next level. Then you need to inject the sperm into the egg through machines which are known as micromanipulators, and the air quality around that and the temperature and all that needs to be maintained there. And more the number of micromanipulators, more the handling operators you have, the less amount of exposure you give to the eggs, because you can do it much faster.
Yes.
So all put together, it's actually a play of space, air quality, and the amount of equipment that you can have in your system, which can actually give you the right kind of environment for the culture of the embryos. So that's the infrastructure part. But top of that is, of course, the manpower. Your embryologist is the heart of the whole system. He or she should have enough training, experience, and ability to troubleshoot, because things will go wrong. So that person should be enough experienced to be able to handle all of it. And ideally, you should not depend on one person. They should not be on one. This is one situation. There's too many cooks is actually good for the broth, because you would want multiple people to handle the gametes at multiple times, and everyone knows what they're doing. So it has to be a well-oiled machine, because more the people to handle. In fact, what we do in our system is we have a double witnessing. No activity or no event in the lab can take place with one person around.
Interesting.
There's one person to do it, and there's another person to watch you doing it, so there's no confusion regarding the mixing up of gametes. So we call this double witnessing. Nowadays, double witnessing or manual double witnessing has been replaced by electronic witnessing. So that's again a position where you want to be at the top of your game. You want to have every event that takes place in your lab to be electronically witnessed, so that you're ensuring that the gametes do not get mixed up in your lab. So this is how things pile up. And while all of this is available in our country, you need the right kind of work. Your lab should be sufficiently busy to be able to utilize these equipments and infrastructure on a regular basis, and you should be making enough money to be able to replace them at the right time. So it's actually the whole play, to be very honest. You could have the best of equipments when you start off, and because you don't have that many patients, you cannot really replace them when the time comes, and that's also not good. And you should not be miserly to work with very few equipment, even though you have a huge amount of work going on with you, because then that's also not doing justice. So that ratio has to be worked out. Thankfully, because IVF is now standardized, there's a consensus and guidelines which are available, and if you just stick to those consensus guidelines, you can justifiably claim that your lab is the top.
Embryology is a rapidly evolving area in IVF, but not much is known about how it has evolved. You have dwelled some part of the embryology in the previous question, but I would still like to know what are the changes we have seen recently in the recent years in embryology, and how has it helped in improving the outcome of IVF treatment?
So embryologist is basically 80% of your IVF program. Although as clinicians we get to talk to the client and the client knows us, they should appreciate the fact that actually the most important person in the whole system is not us, it is the embryologist. Because they are the ones who are actually making the embryos, they are the ones who are actually culturing the embryos, and most importantly they are the ones who are selecting the embryos to be transferred back to the womb. And therefore the whole process of IVF is hinging on their expertise. The whole embryology thing has also evolved, and it's evolved like nobody's business. It was observe and perform, and from there it has now become a completely organized, structured training program. Now you have courses in embryology, and actually this is a replicable model. If I could say so, it used to be more like a barber's profession, and now it's more like a surgeon's profession. Because now there's a training around it, there's a validation method, and therefore there's an application method. There are kids who are coming out of embryology courses who are so well trained and so well read, well educated, that you can start off with them right away. Whereas earlier, when we started our careers, an embryologist usually meant somebody who's actually spent 5 years in the lab learning the tricks of the trade, and therefore now is sufficiently experienced enough to be relied upon. Today, of course, experience has its own value, but today you could have embryologists who haven't worked in the lab even for more than 6 months, but are equally, if not better, than those who are experienced just because they have read the right things, have trained in the right environment.
So you have explained all the best practices and what are the hallmarks that you should see in a good IVF lab, and I hope this will help our listeners in future also when they are planning for the treatment, in the selection of the clinic and the treatment. So knowing when to seek assistance is a very critical decision. When should a couple seek assistance for reproduction from a fertility specialist?
Again, my answer to that is very simple. They know. When they have tried enough and they haven't gotten pregnant, they know that they need help. And it's best that they decide that they need help rather than we telling them that you wait for 12 months, you wait for 6 months, and then you seek help. Because if a couple has been married but not actively trying for a child, you cannot really push them to see a consultant just because 12 months have passed and they haven't conceived. More and more couples are now coming to see us even before that mandatory 12 months have not expired, because they feel that they've tried enough and not gotten pregnant. My answer to them is, please wait till 12 months are over, because getting pregnant is still a chance thing, and there is a 85-86% probability that you may get pregnant in the first 1 year of trying, especially if you're a young couple. But even other couples who have been trying and not getting pregnant, they somehow know that they have tried enough and they should have gotten pregnant by that time, and now is the time to see a consultant who deals with reproductive medicine. The hitch is actually when they see you, they accept that they have an issue, but they're not mentally prepared to move on with the active treatment, because there is this lag between accepting that we have a problem to getting down to getting treated for that problem. They would want another couple of months to really get used to the whole scenario and then get the treatment. Very comfortable for me, because your heart should be in your treatment, because if you're not mentally ready for treatment, your treatment is not going to go right. So see a consultant when you feel that you're not getting pregnant and there is a problem around. If you've been married for more than 12 months, then definitely that's a time. If you're married or trying for less than 12 months, give yourself a couple of months before you see us. Once you've seen us and we have actually found something that needs to be corrected, changed in your case, if you're not mentally okay, take a couple of months, put a date on your calendar and decide that by this time if it doesn't work, then I'm going to move on. But then be a little more proactive in getting yourself treated. Because just by seeing a consultant, you're not going to get pregnant. You're going to get pregnant if you act on the consultant's advice.
So what is your advice to couples once they come to know that they need to go through the fertility route? What is the best way to be prepared, both mentally, financially, otherwise, everywhere?
So very simply, you have to do what needs to be done. I say if you're not able to see things properly, you need glasses. And there's no need to delay just because glasses don't look good on you. it's a requirement of your body that you need glasses, go ahead and buy a set of glasses and start working. So if it hasn't worked for you, and if there's something that the consultant or somebody else has been able to identify as a possible cause, think about it, read about it, but once you're convinced, do not delay, get started. The treatment in itself is, of course, very, very taxing. The physical part is not very taxing. It can be explained, it can be accepted by the body also. There is a financial involvement, there is a mental involvement, there's a environmental issue. Your family, your friends, everyone else has to get in sync with you that this is the right time for you and this is your thing, you're getting yourself treated, and that doesn't make you less of a man or a woman. And when all these are in place, your mental makeup is right, then you should get into the treatment part. Financials, I know that this is a big concern. We are expensive. I wouldn't say we are expensive, but yes, the whole treatment protocols are such that there's a significant amount of cash outgo that happens, and most of it is unfortunately out of pocket. There's no payment system, there's no co-pay, there's no insurance, hardly any insurance in fact. So there has to be a financial arrangement, and you have to have a plan B in place as well, because it may not work in your first attempt, or you should be ready for a second or a third attempt as well. But once all these are in place, that's when you take the plunge, and once you've taken the plunge, stick to it.
So when a couple comes down for the first fertility consultation, what should they expect during the first fertility consultation, and how do they get ready for the entire process?
At my end, I'll tell you very honestly, it's always a very, very tough interview on the first day. Because what we try and do is run a reality check with the couple. It's very, very important that we run a reality check with them, because then they get a sense of what the natural chances of pregnancy per month actually per couple is, and then how we can enhance it or maybe pair it to what natural chances are at most with any kind of a treatment that we have to offer to them, and why multiple cycles or multiple attempts may be necessary for them in most circumstances. So it's not a very happy interview for most of them. It's not like go take a pill for 5 days and you're going to be pregnant with that. But yes, because most of these couples are now read up, are aware, and they've maybe for that, they've listened to us in some of our interviews. They're so well prepared and so well receptive. When they've actually heard this and they now know that this is applicable to them also as a couple, they sit down, they listen to us, and then they get down to the numbers very quickly. And they go back with a sense that this is what they need to do to achieve this level. So this is pretty on table.
Yeah. So coming to success rates, there are basic treatments that you talked about, IUI, and then there is IVF, and then you have also talked about IVF add-ons. So can you provide some insights on the success rates between these different types of treatments, without add-ons?
So again, let's go into some controversial areas just for us to get a better sense. So you cannot expect any of these treatments to be a 100% successful method per attempt or per try, simply because human body is not such designed. So success is again itself a very tricky word. We are happy because we are making embryos and we get success by that. But the client is not looking at embryos, she is not also looking at getting pregnant. She wants to deliver a healthy baby. So her sense of success is entirely different from our sense of success. How do you marry the two, or how do you merge the two? We talk about the live birth rates more than we talk about embryo formation or getting pregnant. So today and in all our subsequent conversations, we'd like to talk about live birth. So what is live birth? Live birth is the probability of you having a healthy born after you've gotten pregnant through a particular method in a particular attempt. In that sense, an IVF or an ICSI have pretty much comparable success rates, and that's close to, let's say, anywhere from 20% in a couple who are 37, where the female partner is 37 or thereabouts, to maybe a highest of 60% if the lady is around 25, 26 years old. So you range in between that zone. Most of these couples may have a 20% higher chance of getting pregnant, but there's a 20% chance of miscarriage. So it pairs down to 20% chance of a live birth for a 37-year-old lady, to a 60% live birth if you're a 26-year-old lady. So that's the range. And then you put yourself in any of these places and try and look at your own success.
Okay. And how does age factor into this? How does it impact the outcome?
In simple terms, the older you are, the lesser the eggs you have, the more damaged those eggs are because of exposure, environmental and genetic reasons. So therefore, the lesser chances you have. The chances of pregnancy happening to you if you are 45 with an IVF is 2%.
Okay.
And the chances of the pregnancy happening to you if you're 25 is 60%. So that's the range.
So age does have a
huge role. Huge.
So what are the potential risks and complications associated with assisted reproductive techniques?
So the biggest upside of IVF is it's largely safe, or it's become safer over the years. We did have a situation where we to overstimulate the ovaries, and women went into a condition which is known as ovarian hyperstimulation syndrome, which was potentially life-threatening. But now we've segmented the IVF process, so we make embryos in one cycle and transfer them back in another cycle, so that has taken away the risk of hyperstimulation. So the safety aspect is very well taken care of, and that's one of the reasons why there's an explosion of IVF across the country. Regarding the side effects, there are temporary and there are long-term side effects. The temporary side effects are because we are stimulating the ovaries to make multiple eggs grow up, the estrogen level goes up, and then that causes a significant amount of side effect, temporary. You have mood swings, you have irritability, you may have heaviness in your tummy, you could have some vision issues, headache, migraine, and things associated with those kind of conditions. But they are transient. They go away once the eggs have come back to, the ovaries have come back to normal size, so that's around 10 to 12 days. The long-term effect, not really that common, extremely rare I would say, is where you could induce blood clotting issues in the person because of the high estrogenic environment. So that also has to be kept in mind when you're dealing with women who are having such high levels of estrogen while their ovaries are getting stimulated.
Moving on to the legal and ethical aspects of IVF, there have been a lot of amendments in IVF laws, and yes, there has been a conscious effort to regulate IVF and to standardize it, not only in the interest of the couples but also in the interest of the donors and surrogates who are part of the third-party reproduction. So can you talk a little bit about the current scenario of Indian ART law in terms of surrogacy and donors as well?
Okay, so this is a question that needs to be addressed, and needs to be addressed with due seriousness. IVF is a process where we make embryos and put it back to the woman's womb, and the whole thing is such that it has a lot of emotional implications. Getting pregnant, not being able to get pregnant, spending money to get pregnant but still ending up with no pregnancy, all of these may have significant emotional challenges both for the client couple and also for the treating physician or the treating team, and very often there could be legal and emotional outbursts. So to handle that, we would both be safer if there was a superstructure of law around it, so that we know that we have done what should be done, and the client also knows that they have done what could be done. So that is what the whole story is all about. There was no law as such in our country. There were guidelines which had the acceptance of a law, but the actual law came in quite recently in 2021, and the regulation of the ART process or the practices in our country, and also the surrogacy law also came at the same time. And they have done a lot of things, a lot of good things for regulating the entire IVF process in our country. The summary of the whole thing is, of course, the client couple now knows what constitutes a proper IVF clinic. There are certain do's and don'ts that all registered clinics have to comply with, and the client can actually find out whether all these are in places or not. They can actually go in and ask if this is a registered IVF unit or not. We are also supposed to respond to the authorities regarding the work that we do, the outcomes that we have. We have a reporting format. We have to send them results or reports every month, and that's a wonderful thing to do, and that's a wonderful start, I would say. It would be better if this all moves in electronic and we have to report on a more frequent basis. it is also ensured that situation where we're not getting pregnancy with our own gametes and we have to take gametes from donors, whether it's a donor egg or a donor sperm, so then we are regulating that part also. Previously it was all hidden, opaque, because the client would approach the clinic and the clinic would take the responsibility on itself to provide you a donor. And you wouldn't really know whether the donor was actually a donor or somebody else's eggs being masqueraded as donor eggs, or whether the donor's eggs were divided amongst 10 recipients or 2 recipients, and so on and so forth. Now what the law is doing is a donor can donate only once for a recipient, and that also without any monetary consideration. So it has taken away the business aspect from the whole, it's completely out. You are expected to donate out of your free will. There's no coercion involved now. And the client is responsible for getting the donor. And this is something that is very, very important. So many times the clients approach us and tell us, why don't you get us a donor? No, that's not our job. Our job is to perform the IVF procedure. And the procedure needs a donor gamete, then you have to go and get the donor gametes. There have been banks that have been created. You have to approach the bank, talk to them, and they're supposed to find a donor for you. You can get a donor from your family, your friends. A known donor can work for you. But essentially, the donor is your responsibility. Once that comes in, the coercion, the financial emoluments, the whole business part about the whole donor program gets taken away. So that's a wonderful change that's happened. And finally, for surrogacy, there was possibly an element of frivolity about surrogacy. There were newspaper articles. I really do not know, because I'm not into the depth of such matters. But the newspaper articles used to suggest that maybe some couples have undergone surrogacy because they don't want to be encumbered with the whole process of pregnancy, but not because they were suffering from a condition where pregnancy was not possible. And all this got so much noticed and hyped up in the media. Somewhere down the line, we became the surrogacy capital of the world, and we had clients coming in from across the world to get surrogacy done from us. And some of us thought that maybe this is exploitation of human body as such. So now the law is very strict that you have to do surrogacy only when there is a medical necessity for couples who qualify for such procedures. And again, the whole process of surrogacy is governed by altruistic process. It's a not for monetary gain process, which has taken away a lot of shine from the whole surrogacy industry, as it were, and make it more humane, more sensible, and hopefully this is the way it will stay.
Can you explain the role of genetic testing and embryo selection in IVF process? Do you do it routinely in case of failure cases?
So basically, in our country, as the law goes, PGT or pre-implantation genetic testing of embryos can only be done if there is a medical reason to do it and not merely for selection purposes. So in layman's language, what this means is that after we have formed embryos through the process of IVF or ICSI, we look at the growth of the embryo and at the looks of the embryo and then decide to do the embryo transfer. But we as clinicians also have no clue whether this embryo is genetically healthy or not. So ideally what we should do is we should check them genetically before we do the transfer. That will help us achieve a higher amount of live births, reduce the number of miscarriages. But the whole process of PGT is not fully evolved. It's an evolving process. Things are improving. Reporting on such minute DNA that gets extracted from the cells of the embryo is not always perfect. Very few labs have been able to master this technique. So therefore, applying this on a routine basis is just not possible today. So the government has mandated that this be used only in circumstances where a couple has undergone multiple miscarriages, or if there is a specific genetic disease in the family, to rule that out. Now, in couples who have failed IVF treatment, meaning that they have not gotten pregnant with the embryos that we transferred to them, or maybe they had a miscarriage out of the pregnancy that happened through an IVF, it is justified that they ask for a PGT and we offer them a PGT as a treatment or an improvement modality. In fact, in many couples, we do end up doing a PGT for them. But in many other couples, there could be some other reason why the pregnancy did not go through. And blindly offering PGT as a compulsory add-on in all cases of failed cases is not really what we do or we practice.
So we were talking about failures, and the next question that comes to my mind is how do couples deal with these failures? Do we have any kind of resources or support systems in place for couples to help them deal with the stress during the treatment as well as the stress related to failures?
It's unfortunate that IVF, even though it's undergone so much of evolution and perfection over the last 40 years, is still not 100% reliable, in the sense it does not give you a pregnancy every time you attempt an IVF. In fact, less than half of our clients get a pregnancy at their first attempt. So that does create a large pool of clients who have undergone the process of IVF. Possibly that's the best that we could do for them, and they still don't have a pregnancy or a child to show for it. So how do they handle this, or how do we help them handle this? We start at the very start when we keep talking to them that it's not a 100% procedure and you have to be prepared with a plan B, or you may have to mentally prepare for multiple attempts of the whole thing. And that does help, because that means most of our couples have a reality check right at the very beginning. During the IVF process, while the follicles are being grown and while the whole process of maturing of eggs is happening, they take out time and talk to our in-house counselor on multiple occasions to get the same thing getting reinforced in their psyche. Post-ovum pickup also, the first reality check happens is when the embryologist calls them up to tell them that these many eggs were extracted and these many embryos have formed, and therefore all your eggs have not become embryos, and therefore there's a high chance that all your embryos are not going to become pregnancies. So this is kind of a process by which a client is getting prepared through multiple steps. At the first step, meeting me, to the next step, meeting the counselor, to then talking to the embryologist about their IVF summary, that they get a sense that all IVF cycles do not give you a pregnancy. But in many, in fact, I would say in more than 50% circumstances, the client is still not prepared. They have not been able to internalize that they might fail in their first attempt. So then what we do is what is known as a review meeting with them. We try and avoid the words success and failure as far as possible, because by the nature of these words, we try and convey a good versus a bad feeling to them. See, an IVF clicking on your first attempt or not clicking on your first attempt has no bearing on your overall reproductive outcomes. You might go on to give birth in the very next attempt that you take, and you choose to do it with us. We are happy. If you want to do it with somebody else also, it might still work for you. So that's the sense that we try and give to the couples in our review meeting. At times, yes, we may have gone wrong in the sense that we might have triggered at the wrong time, or we may have applied the wrong technique to them and we want to change that in the next attempt. So a review meeting is a very honest understanding of what they underwent and how things can be changed if we choose to do the same thing again. But then also a reinforcement that in most circumstances a failed cycle is not really an admission of failure. It is that particular cycle did not work for them, and the next cycle is a new cycle and might still work for them. And this keeps on happening on such a regular, routine kind of a fashion that most people get accustomed to it, and they try and get themselves organized mentally.
So the next question is the million-dollar question: choosing the right fertility clinic. That's a very critical and crucial decision for a couple. So what should couples look for when choosing a fertility clinic or a fertility specialist for their assisted conception journey? And more importantly, what are the questions that they should be asking?
Okay, so again, this is something that has been played up so many times in conversations and in the social media posts, that we keep seeing this and we see the same stock answers to these kind of questions. My simple answer is there's no clinic in this world that delivers 0% results, and neither is there a clinic that delivers 100% result. So you have to accept that this is how the whole process of IVF is. There are going to be failures, and there are going to be some couples who are going to click on their first attempt. And that's how it happens. You need to understand what you are looking for. You could be a couple with supposedly low chances of success, but you still want to go ahead with your own gametes. You could be a couple who are on a fast track to pregnancy and you don't care how the pregnancy happens, but you want that to happen as quickly as possible and you're okay with donor gametes. So as we keep saying that there's a huge need for us to appreciate what the couple desires or wants and tailor the whole process for them so that it suits them, their pocket, their expectations, their ability to undergo the whole process of treatment, that's where a good clinic versus a not so good clinic comes up. If a clinic is willing to listen to you, is willing to explain in details how they are going to do things which suits you, and if you are comfortable with their explanation, and if you feel that no, this is a clinic that's actually going to do what we want them to do, then that's a good clinic for you. Do not get taken in by things like there's a 80% probability or there's a 60% probability or there's a success rate or we had this many patients got pregnant in the last IVF batch that we did, so and so thing. These are more like marketing, advertisement tools that does not look good or does not sit well with any IVF clinic. There are going to be failures or failed cycles in all of our units. In fact, I keep saying there are more couples who have failed with me than they have succeeded, and that doesn't actually make me a lesser of an IVF consultant because I am proud of what I've done so far. And while we try and continually improve on our techniques and methods, we also need to appreciate that all months, all cycles, all women do not have healthy eggs, and that's how the human body is all designed to be. So multiple attempts is what you need to do for whatever method or technique that you choose to do. And you need to be comfortable with your service provider, with your consultant, that you are the right person or that consultant is the right person to take you through that journey. Do not get stuck on numbers or advertisements because that's just the show item, and that's not really the truth always.
So when you're talking about meeting expectations of couples, from your experience, I'm very curious to know expectations of Indian couples and how is it similar or different from the expectations of NRI couples?
So today is the generation or today is the age we're not supposed to put people in boxes. So I would not really talk about the Indian couple versus the NRI couple per se, but I will definitely talk about the couple who comes taken in by advertisements versus the couple who comes in with his own or her own research. Couples who have been through a system of education is aware that success rates in terms of a live birth per IVF attempt is not 100%. In fact, it is lesser than 50%. Most couples come to us in their late 30s. A more realistic assessment of their success is anywhere in between 30 to 40%. It could go up significantly if they were to choose donor gametes. But to go with donor gametes is their choice, and they may not want to go with donor gametes, and that should be comfortable with me. That is what most of my couples I would like them to believe in, and they should learn this through their own education, through their own internet surfing, as we say, Googling, as we say. As opposed to couples who are stuck on those 70-80% advertisements that are put out regularly, unfortunately, in social media, and then they talk in terms of success rates all the time, and the expectations are such that it's almost impossible to meet them, not even meet them halfway at times. So these are the two kinds of couples that we would talk on a daily basis. We try and make this clear to them in our first meeting that success rates are just a broad indicator, and there's a lot more that goes in. There's something called the satisfaction thing also, because you could want to, or you would want to try with your own gametes, even though your pregnancy rates may not be great because of the whole gamete condition, but then that's within your rights to do so.
Dr. Rohit, I'm very interested to know some of the inspiring success stories that you've had in your experience so far.
See, I've been working for 20 years, so quite obviously I have a whole bunch of stories to share. But for me, my success stories are the ones who did not get pregnant with us while we were trying to get them pregnant, either through IUIs or the IVFs of this world. And then they either went on to conceive in some other unit, or maybe naturally, but they still got back to us to share their good news and joy with us, that now that they are pregnant, they respect, or they really are grateful that we tried our level best to get them pregnant, but we failed to do that. And they still remember us at their moment of joy, and that is what I would say is my best success story. Yes, we have had couples who have conceived against all odds, financial issues, cancer survivors, people who have faced multiple other host of other medical conditions in their past life. We have had kidney transplant women, we had all kinds of patients who've gotten pregnant with us. But I keep coming back to each and every client who's given us the opportunity of trying to work with them. And even when they have failed or we have failed with them, they've still come back and shared their successes with us, taking us as part of their family. So that's what I would say is my success.
That's a beautiful message to take away from this series. Thank you, Dr. Rohit, for your invaluable insights throughout the series.
Pleasure, absolute pleasure.
And to our listeners, we hope with this series, we have been able to give you all the information that you need to navigate the journey to parenthood with assisted conception. Please let us know what your thoughts are about the series in the comments below. If you have any questions or any topic suggestions that you would want us to cover in our upcoming series, please let us know. Remember, knowledge is power, and we are here to serve your curiosity and your interests. Until the next time, I wish you all the very best with your parenthood journeys.